Good afternoon. I am so pleased to be here in EuroPCR, and I want to thank the board for letting me chair this case. So I have no potential conflict of interest. So it was a classic case. So it's a patient. My patient is 76 years old. He has diabetes. He was admitted in to our hospital because of an anterior myocardial infarction. Donc, at the admission, the patient had still pain, and so he had also an acute heart failure, CLIP 2. So we decided to do a primary PCI. We start with injecting the right coronary. It was a dominated right coronary with lesion in the middle part, and the proximal LAD was occluded with a good RCX. So we start with predilatation. We get a flow in the diagonal and a small flow in the LAD. It was a small LAD. Then we put a stent. But we thought that the stent was underexpanded, so we decided to perform post-dilatation. The balloon, I think, was damaged from the beginning because when we tried to dilatate or to deflate the balloon, we see that there is no change. There are no change in the picture, and then when we tried to deflate the balloon and to pull back, it was very difficult. So we make some. We pull back strong, and then what we get, it was. The balloon catheter was broken during the pulling back. After that, the patient developed pain again and ventricular fibrillation. We perform an electric shock and we get again a sinus rhythm, but no. We were very, so we don't know what to do. I think about snare, but we have no snare in the cath lab. What do you think what we will do? If you get this situation in the cath lab, you have the catheter of the balloon, which is broken. The balloon is in the LAD, and the patient is unstable. Have you any idea how to solve this problem? No snare in the cath lab? Yeah?
You could produce your own snare.
No snare.
You can put...
Yeah.
Make your own snare.
With the guide wire, with the wire. With the wire, yeah. It's a solution. So what I did, I put another wire in the aorta, and what I want to do is to jail the remaining part of the catheter. So first attempt, I put, I'm sorry, it doesn't work. I put a wire in the aorta, I pull back a little bit the guiding catheter, and I put another wire in the aorta and try to use another balloon to jail the remaining part of the balloon catheter. The first attempt failed, but I tried again and I succeed to pull back all the catheter, the remaining part of the catheter and the balloon, and here is the balloon that I pulled back. So maybe if I have take a home message in this case, maybe I should not pull back strong on the catheter. Maybe I should try to deflate the balloon with another wire, an hydrophilic wire, and not pull back strong because it could be a catastrophic situation. Thank you.
Thank you.
Any comments? Any comments from the audience? Please.
Nice presentation, thanks. But as a message, I don't agree with you to deflate the balloon with the hydrophilic wire. It's not easy. It's the best thing to do is to deflate the balloon with the backside of the O14 guide wire, which is very stiff. Instead of hydrophilic wire, you can't deflate it.
Yeah.
Anything else? Okay, probably thank you very much, and we are going to end this session with a take-home message from the panelists from my right to my left. Maybe left. Oh,
One question. We've seen a lot of knots from the right axis, right radial axis. And now, in my department, we switched to the left side. I just wanted to know how many procedures you've now done on, or how many colleagues performed from the left radial axis.
There was a recent publication in the JAC stated that only 4%, 4 to 5% of the radial approach are done from the left side.
yeah. Please.
Also after bypass graft, because they have the
bypass,
bypass.
yes, but if we try from right radial with Lima and use an Simmons catheter to go campus.
Okay.
Okay, one last comment from the panel. No. No. No.
If I have a comment, is we should try to put everything in our side during the procedure, and maybe to stick to the leaflet of the device, and don't reuse the device if it's possible, but try not to use reused and re-sterilized items, because these items are done to be used once, not more.
Well, I can go on and on actually. Well, again, this is basic angioplasty, as I had mentioned earlier on. What we do in our center here is, whether it's radial or femoral, is we actually fluoro the guiding wire and intercatheter almost all the way as well. It gives, well, you may argue that there's excess of radiation, but then I think it's sometimes important, because sometimes you have a brachial band here, and we just want to be safe. And one take-home point is, I know everybody wants to do radial. We are also a radial center. We started radial angioplasty in 2005 in Kuala Lumpur, Malaysia, when in America they were only doing 7 to 15% of radial angioplasty at that point in time. You see, the thing is, if you are unable to get proper support through your radial angioplasty access, go to your femoral access. At the end of the day, it's the patient safety that is most important here. It's not what you show on the live cases that you do and the heroic acts that you do. It's for you to be safe. One very important point that was brought up just now is you always pass in your 035 wire all the way in, even if you want to manipulate your guiding catheter, especially for your EBUs. So if you understand your basic, you stick to your basics, you will not go wrong. And the most important thing is, do not panic. If there's a mistake, then fine, tackle it. Okay, if you see no pressure, like someone had mentioned just now, tackle it. First, look at the patient. Okay, look at his blood pressure, look at his ECG. Once you have cardioverted a VF, make sure the patient is alert, is conscious. So these things you adhere to. If you panic, everything goes wrong. Thank you.
And one last comment is that sometimes the difference between a good operator and an excellent operator is being able to solve complications. And sometimes you have to come with a very smart idea, something different that might be the solution for the problem. And also, sometimes we need to remember that perfect is an enemy of good. If you want to do something else and try to have a better result, you might end up having problems or complications like this.
Yeah, an excellent operator prevents complications. He knows when to avoid it, and he knows what can happen.